Day one, listen. Day one.
All right, you guys are ready, just let the class know and then we'll start.
All right, good morning, everybody. As you guys know, I'm Lieutenant Golder. We have Captain Keller, Lieutenant Philippe. And we were encouraged by our Phase 2 site, William Beaumont, to do an ongoing practice, or professional practice evaluation for current anesthesia providers. So our P is anesthesia providers, I is ongoing professional practice evaluation. The C is going to be the current standard operating procedure, SOP, or the current program in which current anesthesia providers are evaluated. The O is the ability to monitor anesthesia provider competency and areas for improvement. And the T is quarterly anesthesia providers ongoing professional practice evaluation. So our PICOT question reads, in currently practicing anesthesia providers, how does the implementation of a new OPPE compared to the current SOP improve the ability to monitor an anesthesia provider's competency and identify areas for improvement in a quarterly evaluation?
So our PICOT question led us to the research question that the implementation of a new OPPE will improve the ability to monitor anesthesia providers' competency and identify areas of improvement compared to the current standard operating procedure in a quarterly evaluation.
So for the rationale, what we have is that a PICOT question, the goal for a good PICOT question is that it's going to direct your literature search so that you get unbiased evidence, or you'll get a lot of literature showing you all the sides of an issue. That would be a PICOT question. It's wider. When you have a research question, it's more of a narrow, if you will. It's more directed towards what you're looking for. So you get less diversity in what you'll come up with as your literature to support. It will mostly support what it is you're trying to, your hypothesis, if you will. So it could potentially be a bias type of set of evidence that you come up with.
And our references, as you guys can see. You guys have any questions?
Actually, I
Okay.
okay, so what does the OPPE stand for?
Ongoing professional practice evaluation.
Okay, and so can you explain to the class what that is?
Basically, so in our contact with William Beaumont, Joint Commission has mandated that anesthesia providers, which we're focusing on, have to have an ongoing professional practice evaluation done. It's either monthly, quarterly, or yearly, and they suggest more often than yearly. And basically what it is it's a tool so that anesthesia providers can be evaluated on the level of care that they provide via metrics that are gleaned from automated anesthesia machines, narcotic counts, peer evaluations, and it just gives the anesthesia provider as well as the institution indication on how proficient the anesthesia provider is and whether they should be allowed to maintain practice, expand their scope of practice. Basically, it's just an evaluation tool that the institution and the providers can use to see where they're at compared to their peers.
Can anybody think of any other questions regarding what they're doing? What is your assessment of the rationale of the difference between the PICOT question, PICOT, and the research questions? What discussion points do you have for your groups? If it's tricky, come on, guys. Think about this. What are your research questions?
Say that. The actual research questions? Okay.
Is that a hypothesis and that's which research question?
Yes. And that's okay. That's okay for the purposes of this class because we wanted to keep it simple, right? But that is a very good point. So, very good point. And then you have it on your slide. Therefore, we didn't really discuss that as much. Right? What did you say on your slide?
The description of the research question?
Right, so you said that for directing your search, right? But you have on the slide that it directs the design of your research, right? But what type of literature search do you want to do for research? Do you want to directed search? Would you use your research question per se in your search?
Yes, well, parts of it, without a doubt, the ongoing professional practice evaluation is going to be a keyword we're going to use because we don't know anything about this. So our literature search is going to begin at the very bottom, starting with what the Joint Commission mandates, what their recommendations are, looking to see if there's any Army regulations that address this issue, seeing if there's any ongoing or current practices at William Beaumont, see what the literature shows by way of results of how the OPPE improves practice.
Okay, peers?
What if it doesn't improve practice? Is your literature search going to show both ways or just one direction?
Usually if you use a research question, depending on what your research question is, you would find literature that mostly supports what that question is. But if you use your PICOT question, then you'll get both sides of the literature. What is good with it and what's the PICOT question.
So you're saying that for a research question, you only want the literature that supports your hypothesis?
You don't want that. But
Okay, good. I just wanted to clarify that. I just want to make sure that that was clear. Okay,
You don't want that.
okay, good. All right, any other questions? All right. Again, so while they're asking questions, the next group start teeing up. So the group that's teeing up, I don't expect you to participate in the discussion. Next group, I want to see more people involved in asking them questions. I don't want you just passively sitting there. This is an active learning experience, and you don't learn unless you start discussing it and sharing ideas, and then you start processing it more than just passively listening to slides, okay? All right.
Kill that thing, man. Hey, just chill it. Can't do a damn thing. Thanks.
All right. Oh, and by the way, I'm using a stopwatch so that we can stay on time. Just so you know, like if I'm starting to, that means you gotta wrap it up, okay?
Are you all set, ma'am, or do you need minutes?
I'm ready when you guys start.
Okay. Good morning, ladies and gentlemen. I'm Lieutenant Cully, here with Major Wimmer and Captains Smithers and Hefner. We are representing the TAMC group today. Our PICO question to present to you is up there on the board for you to read, and I will read it to you as well. For patients undergoing routine surgical procedures, what preoperative labs studies are required in order to provide the highest quality and cost-effective and safe and aesthetic care to the patient during the perioperative period. So this is a very large PICO question that we sought out to tackle, but its importance is an ongoing, evolving question that's in our practice. How can we be best efficient with our resources? How can we best utilize ourselves? And what can we do best for our patients in terms of the armamentarium of studies that we have? All right. So our PICO question led us to this research question here. Does conducting the routine preoperative testing compared to no testing improve patient outcomes and reduce costs for patients undergoing routine surgical procedures? So we use the criteria from our PICO question to then refine this question that we would then use to direct our research onto this subject. I'm trying to say next.
So we're gonna help each other out in your group.
All right, we'll keep going. So I'd already sort of alluded to the significance of the topic that I just discussed a moment ago, but the rationale being, of course, cost-effective care being at the forefront of really any practice. The area of interest is which tests are we going to do for each individualized patient, and what we found in our research or in our search for information to guide this topic was that there are protocols out there and there are guidelines that determine what tests to be ordered, but the sources are only updated so often. And just like every other part of practice, technology evolves, new tests emerge, and we have to determine what is necessary for each patient. So essentially what is being done in practice at the moment is each individual service, whether it be cardiology or pulmonology, has been tasked with the responsibility of coming up with which tests are indicated per patient. And really the main theme is that there's no such thing as a routine test to be ordered anymore. So each test has to be individualized. Presenting the question, what should we do for each patient? So really what we found is that physical exam is really what should determine the types of tests that you order, and that is the current practice. Not every cardio patient gets an EKG, but every patient with certain physical findings should have an EKG or a specific lab study. And what else do I need to tell you guys this morning?
So what were you gonna discuss before, when you were on the last slide? Can you now recall what you wanted to say about that? Just a question.
Trying to think what it was I was trying to say. Sorry.
You can cover it in the next slide.
I think I did cover it in the next slide.
Which is a tie.
Okay.
In terms, I was just trying to tie that in for you in terms of the importance
Okay.
of the topic and where our research question was going.
So you're talking about your, okay, I'm gonna have you guys step aside, let the next group start pulling up, and let's ask you questions then. Okay?
So what's,
What do you call that information you provided on that next slide then? About the information regarding tests?
And we'll take it from there.
So like an ASA
Thorough review of literature is concluded.
so like an ASA two with us?
Correct.
But even more specific than that, in terms of which tests actually need to be done in order.
There's more specific information out there, which teased out. Mitch Morris?
Just to go on the back of that, so is there like a specific subset that you guys want to focus on? Because my concern is what we found is that it's very easy to get really, really broad on these topics, which gives you a lot of information, but it doesn't give you a lot of focus. Is there a specific subset of that population that you guys want to look at, or that they want to look at, whether it's cardiac or neuro or pediatrics or?
We haven't found the subset yet that we want to research deeper into. What we have found, like you, is that like we found one review article that looked at 4,000 different articles that have been written on this. So we feel like it's pretty thoroughly, it's been pretty thoroughly covered. What the triplet people may be looking for is a change in culture or a systems change there. And so we need to get a little closer and find out what the real goal of this project is. It might be more of a process improvement type thing.
So whether it be a specific subset of new pre-op testing that seems to be occurring that may not be affecting the actual patient care during the procedure, or whether, like Captain Smithers had said, whether it just be the general culture of ordering routine labs pre-op. We kind of need to tease that out from our source. Did you have a question as well, Major Fraley?
Pretty much summed up with what Kevin Perry was saying.
Okay, so you have 8 seconds. So you see where we were getting at?
Go ahead.
See where we were getting at that? And now, you guys don't have to provide as much background information. It's up to you. You can have more discussion on what difference you think you're gonna find between the two questions. But either way, that's much better participation from the class. This time I wanna hear from people that didn't speak during the first to presentations, okay? So I'm specifically looking for other people to participate. Just so you know, next presentation, people that are just sitting back quietly, not contributing, I will deduct points from your presentation grade for lack of participation in class. Okay? Fair? Right? Okay. Take it.
So good morning. The faculty at Carl R. Darnell wanted us to talk a little bit about oxytocin administration. So here's our PICO question right off the bat. So in patients undergoing C-section, how does oxytocin administration following the rule of threes compared to current practice guidelines affect uterine tone and blood loss after fetal delivery? So that's after baby's already out after C-section. So just a little bit of background information. What is the rule of threes? Basically, 3 units of vasopressin, slow IV push, and then 3-minute reassessment intervals, and then you can repeat that dose up to 3 times. And then after that, you do a maintenance infusion of 3 units per hour. And current practice varies by institution. So some anesthesia techs will say 3 to 5 units slow IV push. Miller and Barish both say 20 to 40 units in a liter of LR for continuous infusion. Stolting is the one that actually said 3 to 5 units slow IV push. And then more obstetric techs like Chestnut actually addresses the rule of 3, so it's not something that's brand new. It's been in the literature for a little while. Do you guys have any questions about the rule of 3s?
Right, so our research question says, does the administration of oxytocin following the rule of threes correlate with increased uterine tone and decreased blood loss when compared to the current guidelines for oxytocin administration following cesarean delivery? And then, so basically the generally, what's the difference? So the PICO or PICO question is more neutral, no qualifiers, no predictions, whereas the research question is directional, it has expectation, and then there's an interest in the outcome. So basically, the research question is basically setting you up for bias. The next slide is just the okay. So it's setting you up for bias. And we were reading over Biddle, the chapter 14 that was recommended for reading for this. It was kind of interesting to note that where a research situation, I guess, basically created the government paid $20 million basically to have a research study followed through to see like the results on the, I think it was stroke prevention. And anyways, what ended with JAMA, they published, anyways. So, and it ended up being that they had to stop that research project because stroke was basically occurring. There was increased risk of clots. And it was basically a negative study. And they went in and explained all of this in the chapter. And I thought it was kind of interesting regarding our practice and our PICO question. So if we had looked at it from a research standpoint, there would have been bias probably saying, okay, well, the current guidelines are basically saying that we just, open up the Pitocin and just let it flush in, which may not be the best result for the mom, because we were actually seeing some literature that said that approach, which is kind of a current approach right now, or at least what I've seen in practice, is that was it hypotension basically or hypertension?
A lot of
hypertension. Yeah, there was basically a lot of issues for mom using the current guidelines. So we're trying to change. In essence, we're eventually hoping to kind of change practice, but that's not the point of the PICO question. We're just trying to see what the pros and the cons are, and evaluate the research that's currently out there.
So I think Carl R. Kardamsey, I'm trying to say Darnell up here, is looking to go towards the rule of threes.
Yes.
And our brief search of the literature showed support for it, and it is in some obstetric texts right now. So they were kind of clinically wanting to change their institution policy, just the way they do things there.
Yeah.
Towards the rule of threes.
Is there any other questions? Yeah. Mr. Fulton?
Your dosing scheme that Stolting recommended, how frequently was that 3 to 5 being pushed?
It is so vague, and it's always prefaced with varies by institution or institutional policy. Like I feel like they don't want to commit to like a recommended dose. So Stolting said 3 to 5 units slow IV push, and then nothing after that. It didn't say nothing after that. It said if oxytocin is not effective, then move on to methadone.
Right. So now, how does that wrap into evidence-based practice? This specific issue of a lack of commitment in the textbooks and conflictual information in the textbooks, which you guys are going to see with almost everything you look up. RSI, oxytocin, GERD prophylaxis, blah, blah, blah. How does that translate, or how is that important in evidence-based practice? Were you going to answer that?
I think I can.
I have another question here.
Okay, yes, go ahead.
So that's just going to create provider variability, because if we have so many different texts that we consider authorities giving us different options for the same type of problem, aren't providers not going to choose whatever seems best to them or really easiest to them?
So that's the danger of relying on a text instead of looking at the current state of the science. And that's what evidence-based practice is. You're looking at what the literature says now, not what was published from information from 10 years ago or 5 years ago, right? How long does it take information to make it into a text?
18 years.
5%, right? It could, you'll get different numbers, but it's too darn long, right? Obviously, okay? So now, one other question. What happens when people are guilty of scientific misconduct or poor, non-rigorous research? How does that affect you guys in your clinical practice if you're an evidence-based practitioner?
Autism. It's going to skew the data.
You could be, you could,
Decisions based on poor information.
Y'all are good.
okay, so you could misinform patients, you could be acting on poor information, you could even harm patients. In that study that Wilson was talking about, if they would have gone with the company that made the stents and only relied on their literature, they may have actually made more patients have strokes. Okay, time for one more question. Okay, Marocho, go ahead.
Just a quick question again. Would you guys, when you guys do your literature review, would you guys kind of concentrate on those patients experiencing post-op hemorrhage that are receiving DDAP or TDAP, or is that important at all for you guys as far as concentrating on your research?
No, it wouldn't be something that we would narrow our search by. Just, I feel like our field is already pretty narrow with just C-section after baby's born. So.
Okay, and so talking about that, what are the implications of potent inhaled anesthetics with uterine tone? Right. So is it important to clear out that literature and not look at literature that is other than an epidural delivery or spinal delivery? So I hear somebody say no. Then what can you do to make the information you present, if you were doing a systematic review, how do you keep that literature rigorous?
You can categorize like.
You categorize it, right? You say this many studies on general endotracheal anesthetics, this many spinal, this many epidural. This is what was supported by each category. Very good, very good, great. Okay, sorry, this is really exciting to me and not so exciting to you all. Very nice. One more thing before the next group starts. If you presented first or second and you're feeling insecure after you see other people that have had a chance to watch, understand that we always know it's a little bit squeakier on the first couple people, okay? And then people gain momentum. So there's a way, I try to compensate for that is what I'm trying to say. I try to understand that the first couple groups are breaking the ice for everybody else, okay? All right. Yes.
All right. Good morning, everybody. We're the VA group. You know who we are. We're going to be representing the Memphis VA, and our topic actually came about because I'm cheap. we didn't have, it's the truth, we didn't have an assigned topic, and my husband has done amazing things at the gym and wanted to know his body fat and wanted to get some $300 DEXA scan. And I said, well, I bet I could do that on ultrasound for free and not irradiate you. And I pulled some studies, and it actually panned out, yes, you can with the ultrasound and bill for it. And I actually stumbled across 2 studies in the process of just medical applications of ultrasound kind of outside the norm, which led us to this broad umbrella that we've honed down to our PICOT question. So 2 studies just jumped out, Christensen and Zadell from the last couple of years, just showing ultrasound and airway management. We ran it by the VA leadership. They love it. And that segued into our initial topic.
So we wanted to ask, in the veteran population, how does ultrasound, compared with standard indicators such as end-tidal CO2 or auscultation, influence verification of accurate endotracheal tube placement? Assuming the null hypothesis that the current and standard indicators are accurate and adequate, we wanted to see that if ultrasound, or assuming the null that ultrasound will not improve the accuracy, it further honed our research question: does the use of ultrasound improve the accuracy of confirmed endotracheal tube placement?
Okay, so in choosing our PICO question, we started with the template from Melnick about a predictor prognostic PICO question. It's a clinical question, so it's non-directional. It needs to be broad, but with specific keywords, so that you are gaining all the evidence. So there is no bias, so you're seeing both sides of the coin. It should be clinically focused and relevant. But Biddle says that time is one of the biggest barriers to implementing EVP and searching relevantly for EVP. So choosing the right words, making it broad yet specific is very important. Once we have all the evidence, we can apply it, formulate a plan, apply it, and implement best practice based on what our broad research, broad evidence search shows.
In formulating our research question, we wanted to, using Justin's experience and our hypothesis that ultrasound will actually improve the accuracy of placement of ET2. And so that's going to be a directional view, and we want to integrate, or recognize what our independent variables. Independent variable is going to be the ultrasound device, and dependent variables are going to be the ET2 placement. And there's our references.
Okay, yeah. So while they're answering questions, next group start teeing up, and let's see where we are.
How is this used, Justin?
Yeah, how do you use it?
So there's a couple. So in the literature, there's about 35 studies that have actually looked at this between primarily surgical and emergency literature. And the technique is basically you can use it as a direct confirmation to see the cord see the tube passing through the cords, or through to secondary conferment. So just because we have, in one of the studies we referenced talks about this, just because you have an end-tidal CO2 waveform doesn't necessarily say you're not right at the carino or in the wrong spot. With direct visualization, you can go directly below the cords, make sure you're in a proper place with better placement. Low cardiac output states may produce a lower CO2 level that may be harder to pick. So somebody in cardiac arrest, it may be difficult to get a good waveform during your compressions. This allows for direct visualization. And the technique is fill the balloon with saline, and you can actually visualize the entire airway lumen now because you've gotten rid of the airspace.
We're trying to figure out what was going to be visualized without the same.
You're doing it as you're doing it as you're putting it in? Or
There is
after?
literature you can do that. We want to focus on the side of after it's already been confirmed through standard means, do we enhance the accuracy of that placement through a secondary confirmation using ultrasound?
For example, after a position change in the OR, you auscultate, you look at the end-tidal CO2, but it doesn't necessarily mean your tube has moved. So looking at the ideal placement.
So how are you going to be able to see if the structure of looking at the carina is not visualized on ultrasound?
Correct, but you can see the rhythmic glottis. You can see the cords, and going just below that, if you're within 1 centimeter of them, you know you're not down to the carina.
Is this a one provider technique or a 2 provider technique?
It can be performed by one provider, but if you do an adjustment, you will need somebody to adjust your balloon.
Any questions regarding PICO or research? That the clinical questions are also interesting. Yes.
For your PICO question, you have those standard indicators in parentheses. How do you expect those would change what you do come up with? And would you specifically include certain standards in your
research? In the PICO question when you search?
So we haven't, yes, we haven't gone through and done a defined search of what are all the current indicators. Those were just two of these standard examples. There are more. We're not saying to get rid of those. We're saying we wouldn't have to do research to make sure we include a specific indicator or couple into the actual research.
So are you all clear on how that works? If you have a broad term and you know that there are some specific indicators or that people are operationalizing those things in the literature, do you all understand the purpose of saying something like standard prognosticators and then spelling it out? How does that alter your search, or how does that play into your search? Okay, so you start out and you search for that general term, and then when you're looking at your literature for what you keep and what you discard, you're looking for items that fall, that address the specifics in the parenthesis. Or if your initial hit is 23,000 articles, then you start narrowing it down by using or Boolean, right? You don't want to use and, because then you're only going to pull up the articles that state all of the items, but you say the ors. And then it will pick up any article that addresses any of the standard ways. And that ensures what? What is that going to ensure for y'all in your search? Coverage, and one other thing. What's important with any literature search? It's not biased. You all have that clear. What? Comprehensive, we got that.
Valid?
Valid, meaning somebody else can do what? Someone else can reproduce it. They have transparency in what you've done, and they can go back right behind you and reproduce the exact same thing, minus any new literature that's put into the database. So that's why if you decide you're interested in an area of research, like you guys are interested in this oxytocin, you're interested in prognosticators of airway, right? Get on the RSS feed. Then every time a new article comes out on your topic, you have it. So if you publish something or want to publish something, you don't have to go back and redo the entire search because 3 months have passed. All you have to do is add the new RSS feeds. Okay? Now, if you waited a year, you need to go back and amend your search. Good? So is that a good learning point? Excellent. Great. I like the conversation.
Hi everyone, it's the DDMAC team. Here's our paper question, or here's some background information, excuse me. So basically, our phase 2 study directed that one of the options, the one that we chose, was kind of a comparison of LMAs, second generation LMAs versus endotracheal tubes, and how they're effective in like low risk kind of surgeries undergoing laparoscopic procedures. So we just kind of first off start with a little background information to make sure that we're first of all like what the second generation LMA versus the first generation, and some of the basic differences, which we're already kind of familiar with because we've taken some airway, got some airway different instruction on those instruments. So just kind of basic what we know about endotracheal tubes, most definitive airway, protects against aspiration, versus LMA, which is a good option, less invasive, doesn't instrument the airway. However, you don't get the gastric aspiration protection from that because you're not isolating the trachea. And also about laparoscopic surgery, some of the unique characteristics of that that you kind of have to understand, so you understand why they're asking about that particular population in this PICO question. Is that you can have decreased efficacy, increased peak pressures during laparoscopic procedure, which could potentially increase the risk of aspiration. So yeah.
Okay, so for our PICO breakdown, our population is patients undergoing laparoscopic procedures. Our intervention is going to see what's going to happen with the use of a second generation LMA. Comparison, use of a cuffed ET tube. And outcome is the anesthetic complications. And time is intraoperatively and long-term. Not much literature on long-term, but intra-op and immediately post-op, there's a lot of information. So our PICO question is this. In patients undergoing laparoscopic procedures, is there a difference in the occurrence of anesthetic complications when using a second generation LMA compared to a cuffed endotracheal tube. That's strictly background, we're using background information, and it's not biased, so we're just looking, is there a difference at all?
Okay, so our research question that piggybacks off of that, basically we made it directional. So we want to know if the use of the second generation LMA would actually decrease the complications compared to the endotracheal tube in the same population of patients undergoing laparoscopic surgery. And then as far as a comparison of the two, this is something that we've kind of already talked about today with multiple different groups, but basically for our PICO question, no direction. We want to see both sides of the argument, whether it's for or against the LMA. And then our research question, we want to specifically see if the LMA is better. So we give that a direction. All right. Any
Okay,
questions?
questions, and next group to you. Go ahead.
What mile potty score are you integrating into your research, or is that a variable?
Well, mild is not a variable. I think it's more about less than about the airway assessment exactly, and more about just like AC1, AC2. At least that's what a lot of the literature that these kinds of things have been done on, and just the general use of like airway. For all the different like sources that we've seen, it doesn't really distinguish between mild potty scores. If it's a high risk airway, then they're not really being included in some of the studies that we've seen.
Why? Why would they not use? Okay, first of all, what's the most important indicator for LMA placement? What acronym do you use? And is melon potty really a big player in that? Right, lemons. So more has to do with their body habitus, right? Okay, that's good though. And then why would they not then include that in the study? Malum potty or somebody who looks like they have an untoward airway assessment.
If they have a contraindication for supraclavic airway, then you wouldn't want to then get a contraindication.
How would you get it through an IRB? I know this joker's got a bad airway, but I'm going to play around with an LMA. IRB's going to be like, yeah, do that study, right? Okay, good. And what else would happen? Even if we were back 40 years ago when we could inject people with syphilis, okay, and get away with it.
Wait, 40 years ago that was good?
What?
Well, not too long. Tuskegee is what?
Well,
Well, they still let it roll on for another couple decades. They let their kids pass it on to their kids. Never told them they had syphilis, so their kids came out with birth defects, yada yada. Okay, so anywho, let's say we're cool with that. We don't have rigorous IRB. What happens to the science?
You get bad science.
You could have skewed results from not controlling for all the variables, right? You have to control for all the variables when you're doing an RCT. Now, if you're just doing a straight up observational study, then you'd have a more real picture. But what are your real correlations? Are they clear? What's a real correlate and what's not? Not until you get to the RCT. Okay.
What are the anesthetic complications of using those drugs?
Like sore throat related post-op
Aspiration.
aspiration. Like I said, long-term effects, we couldn't really find anything regarding that in literature. The main thing is this.
You could find stenosis for endotracheal intubation. Tracheal stenosis is a risk of endotracheal intubation, just FYI.
Right.
Okay? Anybody? Who have I not heard from yet? Question. Richards. You have a question for you?
I think he just asked the question that I was
okay
dealing with the long-term implications.
Okay,
It
well,
wasn't very well defined for me.
Any evidence-based or research questions? Someone else that's been quiet.
I guess I'm just interested in the cost. So
Okay.
I think an ET tube costs a lot less, but provides more safety to my patient than an LMA.
Yeah, it's about it's a little over $1 for an endotracheal tube. It's about $50 for an LMA.
Okay. So you guys talked about cost. What's another thing? You talked about risks. You're talking about risk for the LMA. So aspiration. You can also have recurrent laryngeal nerve damage from the non-flexible newer ones, right? Like the AirQ has been associated with recurrent laryngeal nerve damage.
Okay,
These
so-
might be used in second generation, those, because those are the ones that get the ability to suction and place an OG through, which could help decrease your risk of having aspiration.
Right, so just when you're looking at that, then you start, the more you get into the literature, the more you'll see, okay, yes.
What would, I don't know if this would even be an implication or an issue or not, but how about medications that you would use to like place either an LMA or an endotracheotomy? Would that come into confounding factor?
What your induction sequence would be?
Yeah, I mean, would that matter at all? I don't know if.
I mean, if you're, the only thing that comes to mind immediately would be like, if you're giving something that's known to cause MSS, would be like accommodate maybe that, you know, if everybody uses placing LMA using accommodate, but we're aspirating, well, then you might be skewing your data if you're not using the same induction. That's a good question though.
Yeah.
I haven't seen, in the studies that we were pulling up that were basically, everything that we've seen so far shows there's no difference in the short term, at least intraoperative complications, and I haven't seen anything that's controlled for or specifies like everybody has the same induction sequence. So that's a good question. That's something we have to delve into more.
So you might have like in a meta-analysis type of situation where you can't make a clear comparative because there's so many different types of studies. So then when you write up that literature review, you would have to state that they are comparing different induction sequences and that there are more studies that are needed comparing between the two. Okay, this is good because you guys are seeing how science develops so that it translates to the bedside and it's actually value added and you're not applying junk information to your patients thinking that it's optimal. Great, so we're out of time. Next group, and then you guys let me know when you're getting close to break. I know we're a little bit early, but I don't know if you guys take up on this. Does anybody need to run for break? One more group and we'll break, okay? Good, good. All right, let me get to my stopwatch.
You can do it.
Okay. Wonder Twins.
All right, Major Friendly, Captain Enthusiast. We're one of two groups from Madigan. They gave us quite a long list of opportunities for these capstone projects. So we did a little of this to see who got which one. We got this alvimipam question. One of the CRNAs that are at Madigan right now had a question about whether or not alvimipam versus opioid excess essentially would benefit patients with total joint replacements. So we'll get into that a little bit later. But alvimipam essentially is a peripherally acting opioid antagonist, but it doesn't take away the opioid effects centrally. So specifically looking at ileus, post-op ileus, and all that GI immotility, I guess, that patients get following these large surgeries.
So our PICO question that we developed was in adults receiving total joint replacement. How does alvimipam compare to current standards of care on affecting post-op ileus by the time of discharge? The reason we actually narrowed it down to by time of discharge is because Interreg or alvimipam is only used in the hospital. It's not something that they will prescribe as outpatient. I think we read that they would actually start it day before surgery and then actually ends day of, if not day after surgery. They don't continue it through their entire stay. And then that led us to our research question, which is alvimipam more effective in preventing post-op ileus than current standards of care? And that would be the things like early ambulation, giving Reglan, something like that actually increases the bowels. And we also chose with the joint replacements because they usually have a higher narcotic demand, and you usually can't use this. I think actually most of the research we found was using this with bowel patients to actually block the effects peripherally, so their bowels would start working again sooner.
So kind of reference-wise, I know there was slideshow references, and then these are some of the references we already found, research studies, and as Captain Malthus already mentioned, a lot of these referred to open bowel cases, laparoscopic bowel cases, and Captain Richards even brought that up, said, I think you'll find mostly bowel cases with this, and she was right. Nothing we found to date had anything regarding joint replacements and the use of this drug. So when we get into the research aspect of this, it's going to, it might be a little complicated. We'll have to talk to the CRNAs that are at the site to see kind of what they've already determined or what they've found regarding the use of this drug with joint replacements.
Oh, yeah, there we go.
Let's get some questions.
Did the literature support anything about this helping out with post-op nausea vomiting?
These 5 articles that I read, nothing yet. I've seen nothing on nausea vomiting.
Do you know if your facility was having issues with post-op ileus and delayed discharge, or was this just somebody saw something cool in the literature and wanted to see if it was worth?
Actually, one of the CRNAs just started noticing that the ortho surgeons every case, every time was using albimapam. So he started going, well, why? What's going on? He started looking at it and he presented it to us.
Yeah. So not so much to know if it was a delayed discharge thing or not, but it was definitely something he was noticing.
That's something we were wanting to look at is like the cost benefit, because this is an expensive drug. So we're wanting to see if patients that don't develop a post-op ileus, what that is in cost-wise if they do to treat that, the extra hospital stays, et cetera, versus giving this drug preventively to
Right, if they have a bad enough ileus, they can end up in the OR for another procedure, increasing morbidity and mortality as well. Right?
Sir, you actually answered my question before.
Great. Good job.
Did any of your research find that any of these studies were ended prematurely for pain control issues or any other sort of potentially confounding problems?
Haven't gotten that deep yet.
Okay.
No. Good question. Thanks. Definitely.
How would you potentially change your question to measure what you were saying about the cost effectiveness?
We'd probably just tweak it and then extend it into the extreme post-op, and then in patients that do develop bowel obstruction or ileus, find out what the cost is from that. I really don't know how we would do that.
So in blah, 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 what is the cost of using blah, blah, blah?
Of using the more expensive drug to prevent post-op ileus versus
Right.
a long
So
hospital
it
stay.
is.
Yeah.
Yeah.
Treating post-op ileus. Yeah, I think that's probably a good way to tweak it.
And you guys are doing a systematic review. So you could do a systematic review through that JBI program that actually has a cost effectiveness template. And it helps to calculate that cost of the different interventions. Very good.
So is your research that you're doing, is that also like you're giving it prophylactically, or is your research that does it treat the ileus?
So what Cal had mentioned and what the CRA at Madigan had stated was that ortho starts giving this drug pre-operatively, so prophylactic and post-operative.
Okay, so but what is like the literature coming back? Are there studies that are prophylactic administration of this drug, or are they mostly like just treatment of ileus?
Yes, the studies that we found have that similar context, so they're using it prophylactically, but like you said, only a day prior, max of like 3 days, I think, is what the consistency has been with a few of those articles.
Okay, we have time for one more question.
Yeah.
Go ahead, Bill. Oh, he had his hand up. I'm sorry.
We've been there for a while.
So what patient population are you going to do this in?
We're actually going to look at doing it mainly for the total joint replacement.
Right.
So like hips, knees, big joints like that, mainly because of the post-op pain.
So what would you do on your question for your search?
We could actually narrow it down to
You can keep it broad.
keep it like
but
it
what's
is, but filtered, or maybe it's just knees.
Putting surgery types
Yes,
in here, right?
in parentheses, put your surgery types that you're specifically looking at. And then are you gonna limit by age groups?
We're doing an adult population,
So you just need to define adults.
yeah. Right.
So that's fine. And then realize that doesn't mean it's a bad search. Since you guys are doing systematic review, just means that you have to count for in your write-up, in your discussion, there may be a difference in adult population that are not older adults, greater than 65 years of age, blah, 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 blah. Okay? Very
Kind of
good.
torn on that one still because Madigan takes care of a lot of geriatric population, and those tend to be the
You may need all the adults you can get right now because it's new literature. And later on, they can start narrowing it down. All right, we're out of time. You guys want to, after when we come back, if we have extra time, write down your questions for a specific group, and I know who you are. this. You use your like such and such is the ProConnect, okay? Because you sound more educated, you sound like you understand anesthesia, and it will make life easier for you in phase 2, and you sound like you know your topic. Great, wonderful. All right. See you in what? You guys need like 7 minutes? And then we do it in small so that we're fresh. 2 7-minute breaks, fair? That's my word for the day, fair? Yes. Yes, yes. So you like that word? Okay.
The new version.
Is that it?
Good morning. Let's get started, please. Let's get started, please.
Can we go on break? If you're
started,
gonna
please.
stay
Let's get started,
till
please.
our break, we're gonna start with the next group. All right?
Good morning.
Good morning.
I'm Major Morris. Lieutenant Castano. Kevin Richards. We're going to talk to you today about thrombo. It's this big word. It's TEG, thromboelastography. And you guys are going to sit there and go, what is that? Because we got this suggestion from Madigan. By the way, we are the better part of the Madigan crew. We're the A team, they're the B team. Just thought I'd say that. All right. So anyhow, so what's TEG? So TEG is a point of care testing item that we can actually use in the OR that can look at actual platelet fibrin clot formation, which is great. We kind of were directed to look at like a cost-benefit analysis on this because we're looking at the fact that this is a very expensive piece of equipment, very expensive tool, versus comparatively for regular coagulation studies that we're aware of. Just a quick research review just to see what the topic was. Besides it being very expensive, the time factor, it's like a 15-20 minute turnaround compared to like an hour plus with the lab. So that being said, that's some background information. Let's go to our PICO.
So population is going to be the patients at risk for intraoperative hemorrhage. Our intervention will be the TEG measurement as opposed to the coagulation studies that are currently being used for the comparison. We're looking at both cost and effectiveness, and we have defined those as time to transfusion, unnecessary blood transfusions, positive and negative outcomes. And once again, the time is going to be in the intraoperative period.
All right, which kind of led us to a research question. Similar to the PICO, just has a little bit more directionality. So in patients at risk for intraoperative hemorrhage, how does the TEG measurement compare with current intraoperative coagulation studies in cost effectiveness to determine if transfusion is even necessary?
Sure. So we already talked about this before as far as the unbiased basis of the PICO question. And so we kind of put it into terms of where is this leading us as far as PICO versus the research question. So the idea we already discussed as far as cost containment wise, is this a cost benefit for these two versus the conventional side? And then with the research question having it be more directionality and kind of honing in on what we really want to look for here. So we'll look at meta-analysis and kind of look, and there already are meta-analysis on this. This has been out since the 1990s, unbeknownst to me, but in the 1990s. And so we're going to look at basically what's the benefit of this and what's the implications as far as transfusion. Are we going to need to transfuse? Is it time to transfusion? Is there, because giving a transfusion is not without itself a risk. So we'll look at that. So that being said, we have quite a few references already. Yeah, that's it.
Major Wimmer. Question?
Is this arterial or venous blood you're going to go on for this?
That's a great question. I have to figure out once we get to our phase 2 site. Boulder, looks like you have a question.
Yes, sir.
Does anybody know the answer to that question? Venous or arterial? It's usually just like you do on a PTT or an ACT. It's similar to doing an ACT or a PTT. Okay.
Boulder?
Yes, sir. So your patients at risk for intraoperative hemorrhage, are you guys going to limit it to actually specific procedures, or how it just seems very broad?
It is, and the reason being is we're going to have to kind of fine tune it as we go. A lot of the studies that we saw so far look for like liver patients, like we discussed yesterday, postpartum patients, which the other group discussed.
Cardiovascular bypass was another big one that has been studied for TEG.
And trauma. So, and that's kind of where we like the.
This is standard at the Mayo Clinic. We had a lecture come in for liver from Mayo Clinic. This is their standard.
How about this?
As far as the references and the stuff, are you finding anything on like pig research, or is this already? Have they did anything with that?
Actually, there's both. So there's the meta-analysis kind of looked at the whole big picture of everything that was out there that I was seeing. There was, there were like randomized control trials with pigs as well as, there's a lot of stuff out there.
So I'm almost positive we used something similar to this when we were doing the ECMO trials on pigs, and it hadn't crossed over to humans yet. Like they hadn't made it because it was almost like a point of care testing, like an ice tap. Yes, they were developing a cartridge for that.
For tags.
Yeah, I have very small experience with this, so maybe clarify for me. My understanding is that this is something that needs to be interpreted down the lab. So how are they doing this point of care at the bedside? And number two, is the person that's drawing this going to be the one that's interpreting it? Because there's quite a bit of like science that goes into measuring the angles of the takeoff from the. So
I was going to say, it's not necessarily at the bedside, but they would send it down to the lab. It's just the turnaround time for this procedure, and then checking to see if it's worth doing this test or if, like, the current studies that they have now. And the big thing that they're looking forward to at Madigan is how effective is it in determining, like, all right, this patient really does need a transfusion, as opposed to, like, ruling out unnecessary transfusion sort of for folks.
Is this looking specifically as far as the platelet firing plot? It's looking to see how the tensile strength for that is, determine whether or not we're missing factors, what factors we should be giving. It's actually an interesting technique.
And just to add on that, it also can tell the difference if there's heparin or low molecular weight heparin in the blood as well, so it can tell the difference between like surgical bleeding versus something that's like an actual coagulant.
Remind the point of service, we're gonna go back to that. Okay, go ahead, Mr. Anderson.
So you say that it has a faster turnaround. How does it compare sensitivity-wise to the current coagulants?
That's not actually.
So part of that, that's going to come with our literature review.
Point of care though?
So it might be a better indicator on that, maybe why it's a standard. Okay, we have Mr. Hefner next, and then Wong.
I just had a question about the point of care, because the TEG point of care gives you numbers, right? And what you're describing is like, is the interpretation of the slope that gives you that number, as opposed to like a ROTEM, which
Thromboelastic implies that there's an actual picture, and they're using that to, like they plot it on charts, like starts as a line, and then you'll see like it'll take off. Sometimes it'll take in that, like based on the person.
Right. So is that the same as a ROTEM, or is that?
There's
similar, but
similar to a ROTEM.
So I don't know for sure, but the slides that our guy had for us, it looked like it was like a portable lab. And so it might be a lot like with in vitro fertilization, where they have somebody actually in the room looking at the eggs, making sure that the swimmer's good when it meets the egg, boom, boom, boom. Okay, so that's a different kind of cost, because you're not just paying for the equipment, but also the person that has expertise in interpreting the lab. So that was that point of service piece. Did you have a question, or you wanted to? Go, yeah.
First of all, Hefner brings up a good point. Does anybody here even know what a ROTEM is?
A what?
Sorry.
I mean, because I know we use that overseas, right?
We use it overseas, and BAMC has it now.
And BAMC does?
The ISR.
Okay. But then the next question I had was, what's the impact of morbidity and mortality? I mean,
Part of our effectiveness component
Okay.
that we will evaluate.
So what's a risk with blood products? We're not as worried about communicable diseases being shared, right? Transfusion reactions, anaphylaxis, what else? Trolley, okay, what else?
Stroke in the elderly.
Stroke in the elderly. What else can it promote? They now have research that demonstrates blood transfusions are correlated with higher cancer rates in recipients of blood. Okay? So, who knows if that's something autoimmune, like the immune system trying to deal with the invading, who knows? Okay, but they're finding correlations now with higher cancer rates in blood. So there are risks to blood. Blood's not benign, right? There's all kinds of risks. So if you can only transfuse when, no joke, they actually need it, then patient outcomes, it seems, would be better. But we don't know that till we look at the state of the science, right? So y'all know what I mean when I'm talking about the state of the science, right? The evidence we have to support our thought process. Other questions? Okay, I think we did.
So we're Lieutenant Burke, Captain Perry, and myself from Fort Bragg doing the background here. Just to give you a heads up, we were given an option to look at IV acetaminophen in its use. So just a little bit of a background. In 2011, the FDA approved it for use in the United States, but it's been used for 20 years in Europe. So a lot of meta-analyses have been done in Europe. Very little has been done here in the United States, and it's so cost prohibitive. So that sort of generated the background to our research and PICOT questions.
So our PICO question, we tried to make it very broad because they wanted us to look at surgical patients. So we left it very broad so that we would encompass all of the research, especially since there's so little done in the United States and stuff. So we used surgical patients receiving general anesthesia because we did want to limit it just to the OR and not IV Tylenol and say the ER or something like that. So we were comparing IV Tylenol to the control of either no acetaminophen or PO or PR acetaminophen. And then we wanted to look at our outcome of how does it affect analgesia, cost, pain score, using that type of, and does it affect or decrease our narcotic use? And we wanted to limit it so that it was by the time they leave from PACU instead of if they got admitted and 2 days later. We wanted to narrow it but still keep it quite broad so that we could encompass all of the research when we were looking for it, which led us to our research question.
So our research question is, in surgical patients receiving general anesthesia, regional or sedation or local, IV acetaminophen or Afirma provides greater efficacy in both cost and reduced pain as compared to standard of care or use of PO, PR, acetaminophen by discharge of PACU time.
So it's a lot. There's actually can be several other research questions that weren't addressed on this initial piece. They want us to look at several different components within the research question. So this is our initial one. It was generated largely in terms of the rationale, in terms of some of the meta-analyses actually use these same type of words to be able to bracket the amount of data that's there. We are going to be using, obviously, European studies to be able to justify this because there's great data from the European side, but we need to understand why it took so long for it to be approved in the United States. And there is some issues which we need to investigate why it took until 2011 to be available. So the surgical population was, as a research question, is much more narrow. You can see that we limited it to specific things that the anesthesia folks would be intervening with because we wanted it anesthesia focused, not general medicine focused. We wanted to also encapsulate the ones that were done in prior meta-analyses to be able to keep that same data that's already been generated from these meta-analyses in the same, looking at the same perspective, although it's been 3 to 5 years later, to see what new data has come out within those same parameters. And then cost as an outcome variable, as I mentioned before, it's about $54 for a dose as compared to pennies for the narcotics or the PO version. So the question is really, is there any rationale? What population is this going to be most specifically used for? Yes, it may work, but is there a better way? Is there something that's less expensive that has the same outcome? So that's our research questions and then our references.
Okay. Awesome.
Gavin Kufal.
My question is in regards to the amount of narcotics used. Because obviously, if you give somebody a whole ton of narcotics, they're probably going to say the pain's better than this. So is there like a range, or is there a specific type of surgery, or because there's a whole lot? You guys have a whole lot of different types of anesthesia and analgesia listed as possibilities to look at.
So obviously, we haven't done the research to know the parameters around it. Really brief background look. They did do several comparison studies of randomized clinical controlled trials looking at, for instance, epidural dose, then giving them IV Tylenol and comparing that to just an epidural dose, and found that, yes, there was less narcotic use. So that's where some of that data comes from. How applicable, how useful it's going to be, and what we're looking at, I don't know yet.
We also didn't want to limit our, by making our PICO too narrow, we didn't want to limit what we could possibly find since, there is a bunch of Europe stuff, but we also want to find everything we can in
And
the
we
States.
wanted to limit it to only the adult population, even though that there's a large pediatric presence at Fort Bragg.
yes, this will help, that, you know, we could miss out on quite a bit. The other thing is we started doing our systematic search of the literature, is that we're finding that there's a lot to support PACU usage, but there's very little as far as any studies really to say how it works in the operating room itself. So looking to see if we can delve a little deeper and see a yes, no. Is it just not being used intraoperatively because nobody's done it? Or is it that it was ineffective so people aren't doing it? So looking at that. And what we're trying to do with our research question is to disprove the null hypothesis that there's no difference between if they receive it or not. And we've got our references. And what are your questions? Yes, good sir.
So in the interoperative period, are you guys just going to be looking to see if there were just changes or comparisons of just heart rate and blood pressure compared to patients that got it and didn't get it?
So what we're looking at with this is, yes, basically, if they have the Tylenol that was given pretty much preoperatively or at the beginning of the case, are they showing fewer of the blood pressure and other things that lead you as the anesthesia provider to administer the opioid? So what we're looking at is not so much what was his heart rate, but, you know, did the anesthesia provider use 500 mics of fentanyl or 250 throughout the case
What was that?
to maintain the patient?
What are mics?
Excuse me, what are micrograms?
Oh, micrograms.
Yes, pardon my-
Get in the habit
ma'am.
of saying micrograms when you're talking to other anesthesia people. That is one of the biggest issues of miscommunication, is people using short terms like mics, okay?
Yes.
Sorry, not to put you on the spot.
Oh, yes, no problem, thank you, ma'am. Yes.
I'm ignorant in this area. So with the pharmacokinetics of IV, is it, you know, onset wise, is it rapid? Is it like, you know, or is it a slower acting or what's?
It's about 15 minutes.
So 15-minute onset for?
Yes.
Okay.
And it's more rapid, especially whenever you have a patient who's MPO and or about. I mean, you can use. It's been shown to decrease the pain threshold. I know a lot of people they use it post-operatively. Increase the pain threshold. Things wrong. So yes, that's also one of the things. And I was thinking about this question is that you have a lot of aspects going here, not just opiate use. You also have gas use and things of that nature. So I think that you're going to have to look at this in a multi-levels, because if a provider uses more gas versus narcotic, I mean, you're going to have a lot of different things in play.
What's another term for gas?
Oh, inhaled anesthetics.
Thank you.
Yes.
You can even say inhaled anesthetics, okay? I don't want people to think you're talking about farting. Well, you don't know where you're presenting, right? What's your audience?
Yeah.
Okay.
I like the objective you're doing this during interoperative because you can look at actual vital signs and actual objective data.
Yes.
Rather than post-operative.
So endpoints.
Subjective data. But how do you do, like, I know it's look forward a little bit, but how do you do this when you don't blind it to experienced providers?
That's also one of the things, because I think it just depends on what the anesthesiologist practice or the anesthesia provider's practice is. So it would be difficult you would have to pretty much double blind it. You'd have to give it without their knowledge prior to the case, and then.
What's another way? What's another way that you could do it?
What, a retrospective study?
Retrospective,
But if you wanted to randomize and double blind, you could have the pharmacy put it in a bag,
and then
right?
infuse it either way, like the saline
Right.
versus.
And all they have is a number.
Yes.
That participants don't know what that number means. One could be normal saline, the other could be the Tylenol. The Tylenol has a very distinct package, so pharmacy would have to alter that. So there's a risk of contamination by moving it into a different package. Okay, so those are things this is just discussing research. So these are things you can look at. This is getting practice. Why are we talking about this? What is this gonna help you with?
Your
Decision making.
Decision making regarding what?
Regarding pain management
Okay, and the evidence, somebody said,
Evidence where they're not.
this is helping you to appraise the quality of your studies. So when you're trying to decide if this is something that really matters for your patient, if they can say it's a double blind, but when they're describing their double blind, if it sounds like they hung a bottle of propofol or a bottle of Tylenol, which is very distinct, or a white milky substance, you know that the provider knows what they did,
Yes, ma'am.
right? So then the quality of that study just changed a little bit.
Yes.
Okay, good. So those are things you can know in your appraisals. Yes.
So, as far as your inclusion and exclusion criteria, would you include people from the ICU that would be getting maybe IV Tylenol routinely, or somebody coming from the ER that have received IV Tylenol, or would that be an exclusion?
I think probably at this point that would be an exclusion. But, we would have to look at that.
So
Because we don't know, because once again, what we're looking at is the steady state
Right.
versus a one-time dose, which is what a lot of our outpatients would be getting.
So to add to that, maybe when we actually, as we get closer to how we're going to carry this out, maybe we would focus on a certain area, whether it's just ambulatory surgery or specific ortho or
Whatever.
GI, or whatever. Yes.
Did other people have questions? Because if they don't, I have 2 people I want to hear from that I haven't heard from. Major Wimmer, what's your question? Seriously, I'm asking you.
Man, I'm active listening.
He asked one.
Yes.
Yes.
He did ask one.
Okay. Oh, what do you guys count? He asked one.
I did.
Who else hasn't spoke up?
I asked one.
You asked one question, I know. Okay.
You're as red as the zebra cornices.
So this is a thing. I'm not trying to embarrass anybody. This is for the next activity. I'm gonna be paying attention to who asks questions. And it's not the quantity, it's the amount of thought, but I don't want just a few people being the only people providing provocative questions while other people are sitting back, because they're missing out on learning something from you that you're not sharing. Okay, so here's an example. So I'm going to use you as an example, okay, Captain Richard. She came to me with a great question during break that all of you could learn from. So then you guys missed out on the information. So can you share that with them?
Yes, ma'am. It was regarding the albumopam, and it's just because I'm part of that group, so I had this question initially. When you look at the total joint population and the research, you indicated that the current research is the guidance is abdominal surgeries, and you limit your PICO search to total joint, we're kind of missing out on the whole plethora of information as opposed to narrowing just the research question down. That was my question. Are you going to miss out on all that possible literature?
So what she was saying is for the IV Tylenol, if you focus it down just to total joints, and then you see there's only a couple of articles on it because it was actually first initiated for abdominal cases, are you essentially ripping yourself off, right?
Yeah,
So
my thought process was a big cast net for your initial search, and then you start fishing for the little fish with your research.
So what you could do, it doesn't matter to me either way. If you start out limiting by total joint and you only pull a few articles, and then you're looking at the articles and you're praising them and the quality's low, or the level of evidence is low, then maybe you need to cast a larger net. So then how does that translate out with what you're going to do in your capstone, right? So there's a few things. One could be that there's no systematic review specifically for what you're looking at. So you might need to do a systematic review. Another could be that you have enough literature, but it's not specific to your patient population. So you're not going to really probably be able to implement guidelines or something specific for that facility, correct? But based off of a change model that demonstrates that you did a systematic review, you could then look at a retrospective review of those charts to see what's been in practice with the joints and what the outcomes are, right? And then the next group behind you could say, hey, based on the information of this organization and the limited research that we have, this looks like it will work in our patient population, and implement guidelines based off of the previous group's work. Does that kind of fill in the gaps of the picture for you all? Okay.
I have a question kind of on that.
Yeah.
Looking at all your research and when you've done your search and everything, you get this plethora on, you're trying to narrow it down. In our culture, being in the United States, does it matter whether it's, because we're finding a lot from Europe versus the United States. Now
That's an excellent question. Yeah, and I was gonna make that point, forgot. So if you guys wanna sit down, you can, please.
I was looking at this picture initially.
You do need to account for the practice culture in the United States. Why? We're for profit. Yeah, okay, so we have some different regulatory guidelines. We have some different legal ramifications too, right? So here's a perfect example of how I was crushed when I didn't understand this difference. When I was in anesthesia school, I saw practice and I was like, wow, I've never seen people do this. They were bridging C-sections with whiffs of nitrous oxide or with potent inhaled anesthetics, right? And I thought, wow, I've never seen anybody do this. This looks kind of scary. Should I be doing this? So I looked at the literature, and there were a ton of articles that talked about doing that in practice, but they were all European. I wrote an article for the IJNS, and they sent it back to me and said, hey, that's nice, but that's not the standard of practice in the US. The risk for aspiration is too great. We will not publish this. Okay? So if you're not aware of the standards, either in your country or your region or your specific organization, there are some things you're not going to be able to gain any traction on. Now, some of the things are cultures that need to be changed. Like maybe this rule of threes with oxytocin, maybe that's a culture that needs to be changed. Then you get involved in these change models where you find informal leaders. You start showing them the literature. You start getting them interested. They start talking about it. You've got support from your formal leadership. You do in-services. You educate the staff. And then you start implementing change. But that is hard, time-consuming work, right? And then you've got to make sure that you keep it rolling. So you got to pilot it. Make sure it works in the organization. If it doesn't, reevaluate it, tweak it so it's going to fit in that organization, and do it big scale, then follow up, and then ensure that somebody's going to keep reinforcing it. That's how they started you guys know the VAP? In the ICUs using VAP for preventing ventilator-associated pneumonia. That's how those types of guidelines started, was through these humongous evidence-based change projects, right? And you guys are going to learn about these change models, and you're going to start evaluating one as one of your projects. You're going to say, this is the model we selected, and this is why we selected it. So you can see the pros and cons. Question?
Regarding those of us with those projects that are, or these capstones, they end up, there's not a lot of data on them, not a lot of research.
Right.
It almost seems like we're getting ourselves into a situation where we're conducting, or expected to conduct like almost an experiment. So kind of where should we be tailoring our approach to this, and what is the end state for this capstone? Because like I'm going with me kind of enthusiasts, we're like, all right, man, we're gonna give out albumin to these guys, and boom, here we go. I don't know that that's my role, so I don't think that's my role.
That's an excellent question. So that's why we had your site director send questions, because they're going to know what can be supported. Like we talked about, if some hospitals don't understand evidence-based practice and the change model, and they decide if you're doing anything with humans, bang, it's research. And now it's got to go through the IRB and blah, 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 blah. If that culture exists, then you're probably going to be doing a systematic review. Because at the end of the day, you guys have to have a capstone. And we don't want it to be so burdensome that you're not even getting to do clinical. Okay? You've got to come out as Uber practitioners. You guys got to be able to rock anesthesia,
Learning the process of evidence-based practice is incredibly important, but impairing your ability to be a good clinician is not, okay? So we have to see what's feasible as we start honing things down. So your next assignment is search, and you're gonna see what's in there, etc. I want you to be writing those program directors, assistant program directors, and say, this is where we're at. This was our initial PICOT question. This is the results of our search. So there, everything you've given to me, once you start fine tuning it, I want it to go up to your program director and assistant program director. Some of you are already doing that, and they're saying, whoa, 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 we can't do that. We don't have that many ultrasound machines. We can only do it in the pre-op holding. Okay, do you see what I'm saying? So they can start helping you fine tune it to what's going to work in that facility for whatever constraints they have. Is that helpful? So that's great, because I wanted to make that point with you. All right, other questions? Is this useful time? Your questions were good. I like seeing that you're thinking about the research in the PICO. I can obviously see, and this is not a hit on you all, this is just an assessment, that you understand the research because you have experience with it, and you're learning the PICO process. The PICO, everybody's sick of hearing that word. All that is a framework for making sure that you can get at what you need to get at, and that somebody else can repeat that, okay? And that you're getting all of the information you need and not just some of it. And so we're gonna talk about that more when we do the literature search. I'm not super big on doing lectures, but some of the information you definitely need. I hope you guys don't feel like I overly held your hand for the first two assignments, the learning activity and this assignment. I know I was hand-holding a little bit. You have no familiarity with this yet, okay? As we progress, I'm gonna step back and just be rotating around and checking on you, answering questions, but not telling you exactly what to do, okay? I will go back, and over the next couple of days, I'm gonna look at your slides and look at how I evaluated you from my first impression and make sure that it's fair and balanced and that I didn't miss something, yada, 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 okay? I would expect for this first assignment fairly lenient grading, but I will have comments to help you improve, okay? And then after that, then taking off the kid gloves, stepping back and let you start flapping your wings a little bit, okay? Because I want you guys to just be impressive when you get to phase 2. That's really, I want you to have stuff done and be impressive. I want you all to succeed. If I'm calling you out for using slang, it's not to embarrass you all. I don't mean to embarrass anybody. That is not my intention. But I know for a fact you cannot stand up on a podium and present using slang, okay? And I know for a fact you can't use it in report. If you use it in morning report, the sharks are going to come in. The lions will pounce. And I just want to prevent as much heartbreak as possible. And those are easy things to fix here. I uploaded for you all, I hear some heartache over these manuscripts, okay? And I wasn't involved from the very beginning, but it's become a gradable event in my course, all right? I uploaded a manuscript, how to write a manuscript article. It's a good article, it's very useful. It may help you all with what you need. I have a book, it's how to report statistics in medicine. You are welcome to borrow it. If you have any type of specific statistics like correlations, it step by step tells you how you present correlations in scientific writing. It tells you how to do it. You just plug in more specific information, but it outlines it for you. And this is based off of what is accepted in research reporting. So it'll make it easier for your manuscripts. And I feel bad that I didn't have this for y'all earlier, but you're welcome to, and I'll make sure the new class has this book. Okay.
Just you're asking the grade for the manuscript, is that coming from our faculty chair?
That is coming from your faculty chair, okay? That is out of my control. I have not worked with you all, so they are using that rubric. Okay, they're using their manuscript rubric, whichever one they provided to you, either Dr. Johnson's or whatever. Okay, so they will be grading you. If I can help you at all, let me know. That's what I'm here for. Okay, I don't want to counter or anything like that. But if you're struggling over something and you've really been working on it and you can't figure out what they're really asking for, and they feel like they're communicating it well, but you're still not grasping it, I have resources like this that can help you. All right? And I can help coach you through it or walk you through it. Is that good? I want to let you out in 5 minutes. Can I ask you all a favor? Well, 2 favors. One, please give me honest feedback on how this course is going as it's going. So if we are off base, then I can adjust before it's the end of the course and you guys didn't get what you needed. Okay? I would really appreciate that. It's not a requirement, but I appreciate it. I will be marking for participation, right, from here on out. And that's just so that you guys share your knowledge and everybody learns something. You all have different perspectives. You all have something to contribute, not just the people who don't mind talking in front of everyone, okay? Another thing is we're developing the statistics course, and I just want to tell you what I'm thinking and get your feedback because you've been through statistics, and I want to know if you think this would be valuable. It's fresh for you all, right? And I haven't taken it for about 2 years now, so it's not fresh for me all. Okay, so just give me some short feedback, 5 minutes. I think this down and dirty book is going to be my primary text, and it's kind of like it tells you exactly what the test is, what it looks for, and what the assumptions have to be, and then what the alternative would be if it doesn't meet those assumptions. Okay, I think that's the way to present it. Short lecture. There's this other book that I like. Have you all seen this before? It's a little off color, his examples. So when he's talking about different types of statistics tests, he's talking about measuring length of a certain part of the anatomy. And then you're busy chuckling over it, and you're like, oh, wow, I can see the application to this.
Did Dr. Johnson write that book?
This guy's English. This guy's English. He's funny, though. So what it has in it, so I was thinking, I think I can get this in downloadable so nobody has to purchase it. And then this book, I think I got it for $45. It's got every statistic. And then if you have the book, you can go in and do the learning activities, and you can do practice test questions. So I was thinking about doing the learning activity. We'll probably have a time reading, have them do the test questions as a pre-test for knowledge for the first gradable event, and post do the learning activity. So they actually apply the statistic and run it, right? And then those are the gradable events. No tests, no exams. And then every other week, alternating between there'll be groups. 1 week the group will take an article, assess the statistics, and discuss, was it appropriate? Were the assumptions met? What would the alternative have been if they weren't? So, and then the rest of the class will give comments, graded on participation, and then the next week, a guest speaker comes with different types of degrees and share with you, the group, whoever the new group is, their experience with using statistics in their daily life. Okay, so a DNP that's in clinical practice, like Colonel Fider, because she uses statistics in her job for administration leadership. A neuroscience PhD, a nursing PhD, a DNAP. So every other alternating, and so the seminar would be them discussing how they use it and you guys questioning and answering them. What do you guys think? Does that sound like value-added class? 2 credits, so keeping it simple, right? And then you build on it in Dr. Johnson's class, but you get the cement, the foundation, and then I think if the two purchase books are these, then you have the manuscript writing book from the very beginning before you start your research project. What do y'all think? Is that useful?
Are those in-class learning activities?
Excuse me?
Are those in-class learning activities?
No, I think, well, one will be and one will be pre. But the pre, that means the lecture time will be shorter and the seminar time, so they get out like 30 minutes early or
Just
something.
because it's only a 2-hour class, and so
Right,
matching the workload with the hours
right. So I
compared to
think
what
that
else is being taken that semester.
at the very most, an hour for the first and a half an hour for the second half, and then, yeah. Because it's-
in that first semester with all
It's in the first semester, yeah, and that's why I'm trying to make it easy. Those quizzes are easy, right? And then I have to decide, will I grade them on, do I give them the grade they earned from the pre-test? You know, so the people who really tried to understand it get credit for their hard work? Or do I, but based off their reading? Yeah.
Not everyone's a reading.
Exactly, so that's why I'm asking.